Welcome to Chapter 11 of Juvenile Justice. This chapter focuses on treatment programming and trauma-informed care for juvenile offenders, arguably the most clinically rich chapter in the course. The entire rationale of the juvenile justice system is built around the idea of reform rather than punishment. The deeper a young person penetrates into the system, the harder it becomes to redirect them toward a healthy life trajectory. That reality places enormous importance on the quality of treatment programming available to youth, whether in community settings, therapeutic courts, or secure facilities. What this chapter will show you is that juvenile offenders are not simply bad kids who need discipline. The overwhelming majority are struggling with serious diagnosable mental health conditions, traumatic histories, and family environments that have profoundly shaped their behavior. Understanding those realities and knowing how to respond to them with evidence-based interventions is the foundation of effective juvenile justice practice. In this lecture, we will cover the mental health profile of the juvenile offender population, the role of family dysfunction and delinquency, how therapeutic courts operate, the major treatment modalities used with this population, the principles and practice of trauma-informed care, and finally, the distinct considerations for sex and sexuality counseling versus treatment of juvenile sex offenders. Let me walk you through the 6 learning objectives for Chapter 11. The first objective asks you to identify and discuss the various mental health issues that compound the difficulties in treating juvenile offenders. You will see that this population carries a staggering mental health burden, and that multiple co-occurring diagnoses are the rule rather than the exception. The second objective asks you to explain how family of origin issues may be an important consideration for juvenile offenders. The home environment is where socialization begins, and for many serious juvenile offenders, that environment has been profoundly damaging. The third objective asks you to discuss how court programs provide specialized assistance for youth with mental health and substance use issues. We will look at drug courts and juvenile mental health courts, both examples of the therapeutic jurisprudence movement that has reshaped how courts think about their role. The fourth objective asks you to identify various types of treatment modalities used with juvenile offenders. We have a rich menu of evidence-based approaches to cover: family therapy, art therapy, cognitive behavioral therapy in its various forms, anger management, and functional family therapy. The fifth objective asks you to identify and discuss why trauma-informed care should be routinely available for youth in the justice system. The research on trauma prevalence in this population is compelling, and the 3 E's framework gives us a useful way to think about trauma's reach. The sixth objective asks you to distinguish between treatment for youth with sex and sexuality adjustment concerns versus treatment for juvenile sex offenders. These are meaningfully different populations requiring different approaches and understanding. That distinction is important for anyone working in this field. Let's begin with the mental health profile of youth in the juvenile justice system, because the numbers here are remarkable and they set the context for everything else in this chapter. Approximately 70% of youth involved with the juvenile justice system have at least one mental health challenge. To put that in perspective, the rate in the general youth population is about 22%. This is not a minor statistical difference. It reflects a population that is fundamentally different from the broader youth population in terms of psychological vulnerability. Nearly 30% of juvenile offenders have a disorder so severe it seriously disrupts functioning and requires immediate treatment. And approximately 60% of youth in the juvenile justice system have at least 3 diagnosable disorders at the same time. The most common of these are disruptive disorders, anxiety disorders, and substance use disorders. There's an important nuance the research has clarified in recent years. The presence of a mental health disorder does not on its own necessarily predict that a youth will reoffend. What does predict recidivism more strongly is the presence of a substance use disorder, especially when co-occurring with other mental health conditions. This distinction matters for treatment planning. It suggests that addressing substance use must be a central focus, not just an add-on. At the same time, the research is also clear that providing mental health treatment to youth with complex risks can prevent juvenile offending, even when the mental health condition is not itself driving the delinquency. Many of these youth come from disorganized neighborhoods with high rates of poverty and violence, environments that create both mental health vulnerability and delinquency risks simultaneously. Treating the mental health condition may not eliminate environmental risk factors, but it can meaningfully improve outcomes. Now let's look at the specific mental health conditions most commonly encountered among juvenile offenders. These are the conditions that treatment programs are specifically designed to address. Anger and aggression are so visible in this population that we begin there. Anger itself is a normal response to frustration. The problem is what the youth do with it. Some channel aggression constructively through sublimation, competitive sports, debate, art, music. But more commonly, anger leads to destructive aggression, which can take physical forms like violence or psychological forms like deliberate humiliation and social exclusion. Both constitute delinquent conduct in the broadest sense. Depression is the most common mood disorder associated with the offender population. About 1 in 8 adolescents may be suffering from depression, and only about 30% of those receive any treatment. For juveniles, depression often presents as irritability rather than sadness, which makes it easy to misread as attitude or defiance rather than a clinical condition requiring treatment. Suicidal ideation is among the most alarming challenges in this population. Suicide is the third leading cause of death among teenagers in the United States. When youth feel incompetent in areas important to them and lack support from significant people in their lives, hopelessness emerges, and hopelessness is the gateway to depression and suicidal thinking. PTSD and trauma-related disorders are common among abuse survivors, especially prevalent among female offenders and perhaps surprisingly among juvenile sex offenders, many of whom were themselves victimized in their childhood. The connection between victimization and perpetration is one of the most important findings in the research on juvenile sex offending. Substance use disorder requires special attention because of its compounding effect. Adolescence is a particularly vulnerable period for brain development, and substance use during this period can have lifelong consequences. The SBIRT, screening, brief, intervention, and referral to treatment, is the recommended evidence-based tool for identifying substance use in youth across all service settings. Finally, the disruptive impulse control and conduct disorders are the diagnoses most frequently encountered in juvenile corrections. Conduct disorder is particularly significant because it often precedes adult antisocial personality disorder. These youth violate the rights of others, destroy property, lie and manipulate, and engage in serious violations of social norms, often beginning before the age of 13. The home environment is where socialization begins. And for many serious juvenile offenders, that environment has been profoundly problematic. Chapter 11 identifies 3 primary categories of family of origin issues that practitioners must understand. The first is substance abuse in the home. When one or both parents or adult caregivers struggle with substance use, the consequences for children are far-reaching. The home becomes chaotic and unstable. Parental availability is compromised. Parents cycle in and out of treatment, jail, or active use in ways that disrupt attachment and consistency. In many homes affected by parental addiction, children become what researchers call parentified. They take on adult responsibilities like managing the household and caring for their younger siblings. These children may develop a strong sense of responsibility at home while simultaneously failing academically. Even the use of legal substances, like alcohol, can be damaging, particularly in homes where alcohol is associated with violence. The second category is family violence and conflict. Domestic abuse is commonly found in the backgrounds of serious delinquent youth. One particularly notable pattern among male youth transferred to adult court for assault. Many have committed their offense against an abusive stepfather who was harming their mother. These young men are, in a real sense, acting as protectors, and understanding that context is essential for treatment. Among female youth, the response to a violent home is more often to escape it through running away, substance use, or attachment to delinquent peer groups. The third category is child abuse and neglect. And here, the research is unambiguous. Maltreatment in childhood and adolescence is strongly and consistently related to delinquency, including drug use, which shows the connection even when other delinquent behaviors are controlled for. The mechanism appears to be self-efficacy. When children are subjected to abuse, their belief in their own ability to navigate life's challenges is systematically undermined. Low self-efficacy increases the pull of delinquency. This is why treatment programs must address past abuse experiences, not just the presenting behavior, if they are to achieve lasting change. Therapeutic courts represent one of the most significant structural innovations in the juvenile justice system over the past 3 decades. The underlying idea is that traditional courts are not equipped to address the mental health and substance use issues that drive much juvenile offending, and that a specialized court structure with a multidisciplinary team can do so far more effectively. Drug courts were among the first of these specialized courts. Their purpose is to stop the cycle of alcohol and drug abuse through intensive therapeutic supervision rather than traditional prosecution and punishment. The research shows that drug courts improve substance abuse treatment outcomes, reduce crime, and are more cost-effective than standard processing. Youth who graduate from drug courts show dramatically lower recidivism than those who do not. Behavioral indicators during participation, fewer in-program arrests, greater school attendance, lower substance use, are strongly predictive of graduation success. However, there is a significant equity concern. Non-white participants have lower graduation rates and experience higher recidivism during and after the program. This disparity must be taken seriously. It suggests that drug courts as currently designed may not be equally effective for all youth, and that cultural responsiveness and structural equity need to be built into the program designed from the ground up. Juvenile mental health courts emerged from a similar recognition that the standard system cannot adequately serve youth with serious mental illnesses. The Bureau of Justice Assistance defines them as specialized court dockets for defendants with mental illness. Using voluntary participation in judicially supervised treatment plans developed by court staff and mental health professionals. The first was established in 2001, and there are now more than 40 across the country. The model is built on therapeutic jurisprudence, the idea that legal processes can themselves be therapeutic. The court assembles a multidisciplinary team, including mental health professionals, school representatives, family members, and justice system actors to develop an individualized service plan for each youth. The goal is to keep youth in the least restrictive setting possible, out of detention, whenever feasible, and connected to their communities. The Massachusetts Youth Screening Instrument, or MAISY, is one of the most commonly used assessment tools in these courts. Now let's turn to the treatment modalities themselves. These are the specific approaches mental health professionals use when working with juvenile offenders. Family therapy treats the youth's family system rather than just the youth in isolation. The research consistently shows that when interventions strengthen the entire family rather than focusing solely on the youth or solely on the parents, outcomes improve. A youth whose family environment remains dysfunctional is unlikely to sustain gains made in individual treatment. Family therapy is particularly effective for youth with conduct disorders, ODD, and disruptive behavior disorders. Art therapy uses visual arts, music, drama, drawing, sculpting, and expressive writing to create a therapeutic relationship between the clinician and the youth. It works particularly well with youth because it allows them to approach difficult emotions and experiences obliquely, through a creative medium that provides some distance from the raw material. A youth who cannot talk about their trauma may be able to draw it, write about it, or perform it. Art therapy has been shown to improve self-image, self-efficacy, and coping skills, and it has even demonstrated cognitive benefits. Practitioners must hold dual credentials in both the art form and mental health counseling. Cognitive behavioral therapy, or CBT, is the most widely used evidence-based approach in juvenile justice and the backbone of most other modalities. The core principle is that through thoughts drive emotions and emotions drive behavior. For violent or highly criminogenic youth, CBT targets the specific cognitive distortions that support offending. Misreading social cues as threatening, a sense of entitlement, self-justifications for harmful behavior. Moral recognition therapy is a structured group CBT program used widely in juvenile corrections, focusing on confronting belief systems and building higher stages of moral reasoning. Anger management groups use CBT techniques in a short-term group format, typically 8 weeks. Youth learn timeouts, deep breathing, I statements, anger logs, and trigger identification. Substance use counseling follows the SBIRT screening process and uses CBT to help youth anticipate and avoid high-risk situations, manage cravings, and build relapse prevention skills. Finally, functional family therapy, FFT, has been successfully adapted for gang-involved youth as FFTG. A randomized controlled trial found that FFTG significantly reduced delinquency at lower cost than treatment as usual, with the strongest effects among youth at highest risks of gang involvement. Trauma-informed care is perhaps the most important conceptual framework in contemporary juvenile justice practice. As many as half of all youth involved with mental health, child welfare, and juvenile justice systems have experienced multiple traumas. This is not a background factor that can be set aside. In many cases, the trauma is the driving force behind the presenting behavior. The 3 E's of trauma, event, experience, and effects, provide a framework for understanding why trauma is so complex. The event is the objective, measurable occurrence. Physical, emotional, or sexual abuse, domestic or community violence, accidents, natural disasters, war, or terrorism. Events can be witnessed rather than directly experienced and can include exposure to graphic accounts or images. The experience is subjective, how the individual perceives and processes the event. 2 youth who witness the same violent incident may experience it very differently, depending on their age, prior trauma history, cultural background, available support systems, and individual resilience. This is why trauma-informed care resists one-size-fits-all approaches. The effects are the lasting changes in behavior and functioning. The classic symptom cluster includes hyperarousal, being constantly on edge, scanning for threats, unable to regulate aggression, re-experiencing or flashbacks, intrusive memories, nightmares, and avoidance, the fight, flight, or freeze response. Critically, these effects represent adaptations that were functional during the traumatic situation. A youth who stays constantly vigilant because they grew up in a violent home learned that vigilance as a survival strategy. Without a trauma-informed lens, that vigilance looks like defiance or aggression, and it will be misread and mishandled. The Cognitive Behavioral Intervention for Trauma in Schools, or CBITS, is designed for trauma-exposed youth ages 10 to 15. It works to reduce PTSD symptoms, build resilience, and strengthen peer and family support through cognitive techniques, trauma-focused imagery, writing exercises, and group creative projects. Some programs have used songwriting, rap, and graphic novel writing as vehicles for processing a collective trauma. The final substantive section of this chapter addresses sexuality and sex-related treatment, and it requires us to make an important distinction. There is a meaningful difference between general sex and sexuality counseling for adolescents, and specialized treatment for juvenile sex offenders. These are not the same population and they require different approaches. General sex and sexuality counseling addresses the normal developmental questions and challenges that many adolescents face. Gender identity, safe sex practices, teen pregnancy, sexting, pornography exposure, sexual boundaries, and related issues. The recommended approach is youth-centered, empathetic, reflective, and grounded in accurate science-based information delivered in age-appropriate language. Several specific considerations apply when working with adolescents on sexual health. Confidentiality rules for minors are more complicated than for adults. Youth often use different terminology than clinicians. Knowing that terminology and deciding when to use it requires judgment. Many youth will be reluctant to disclose same-sex experiences, incest, or contact with adults due to stigma or fear. Working on sexual health topics with adolescents generally requires more time than with adults. Because their knowledge base is often more limited and the topics may elicit discomfort, humor, or overall avoidance. Treatment for juvenile sex offenders is a more specialized and intensive undertaking. The core challenge is that most juvenile sex offenders have serious cognitive distortions, distorted beliefs about sex, power, consent, and victim relations that have often been reinforced over time through deviant sexual fantasy, particularly during masturbation. These fantasies, paired with the intensity of the sexual response cycle, can create compulsive patterns that resemble obsessive compulsive disorder. Treatment must directly challenge these distortions, but in a non-threatening way. Overly confrontational approaches shut down disclosure and damage the therapeutic alliance. At the same time, honesty is non-negotiable. Sex offenders are typically manipulative, and therapists must be vigilant about being managed rather than doing the managing. CBT and group therapy are the primary modalities. Role plays help youth develop pro-social communication skills. Psychoeducation on the impact of sexual victimization builds empathy. And critically, community and family involvement is essential. Individual treatment alone, without addressing systemic factors, is unlikely to succeed once formal supervision ends. Let me bring Chapter 11 together with the 6 key takeaways. First, the mental health burden carried by youth in the juvenile justice system is enormous. 70% have at least one mental health challenge, 60% have 3 or more co-occurring disorders, and nearly 30% need immediate treatment. This reality must shape how the entire system responds to youth, not just the treatment sector. Second, family of origin issues are not background context. They are central to understanding and treating juvenile delinquency. Substance abuse in the home, domestic violence, and child abuse and neglect all create conditions that systematically undermine a youth's development and increase the pull of delinquency. Treatment that ignores the family system is unlikely to produce lasting change. Third, therapeutic courts represent a meaningful structural reform. Both drug courts and juvenile mental health courts demonstrate that the justice system can serve as a vehicle for treatment rather than just punishment. They work best when genuinely collaborative, culturally responsive, and committed to community-based rather than detention-based responses. Fourth, the treatment modalities, family therapy, CBT, art therapy, anger management, and functional family therapy. Each address specific disorders and work best when carefully matched to the individual youth. No single modality works for everyone, and the evidence most strongly supports evidence-based, individually tailored approaches that address both individual and systemic risk factors. Fifth, trauma-informed care is not optional, it is foundational. Given the prevalence of trauma in this population, any treatment program that does not acknowledge and address traumatic history is likely to misinterpret symptoms, damage the therapeutic relationship, and fail to produce lasting change. Sixth, Sex and sexuality counseling and juvenile sex offender treatment serve different populations with different needs. The former is educational and developmental. The latter requires specialized clinical expertise, direct cognitive confrontation, and robust community and family integration. That concludes Chapter 11. Thank you for watching, and I'll see you in the next lecture.